actually reduced if you see the cardiovascular events, whether it is MI or it is acute coronary syndrome or it is stroke. But then important point is that the mortality in the women in the age group less than 45 has increased if they have cardiovascular disease. Few years back when we were doing medicine, when we were in MD, actually the incidence of MI in less than 50 was to be said to be rare. But today the situation is not like that. And many years back, maybe 7-8 years back, when I was in Mundra, a 26 years old lady walked in the casualty with chest pain, and I dismissed the case because the ECG was normal and I sent her back. And a few hours later, she presented again in casualty with full-blown anterior MI. And we did the angio and emergency, and it was a total left anterior descending was acute. So, I mean, now in today's world, age is no criteria, it is no bar to dismiss any case, whether it is a child, because now many of children have come up after this corona with Kawasaki's disease, presenting as chest pain. It's nothing to be nothing should be dismissed, because the only symptom that we are supposed to respect is what the patient is saying. That should become the borderline of our diagnosis. And even if the ECG is normal, even if other tests are normal, whatever the patient says should be golden to us. Because nobody wishes to come to a hospital, which we should understand. It is not a restaurant where you go and enjoy it. If somebody is coming, we need to understand that there has to be some problem, whether it is minor problem or major problem. So, important to understand is that now, since less than 45 have also started coming up with coronary heart disease, mortality in that segment, in that age group has actually not come down. And it is higher as compared to mortality in the higher age group. Now, mortality is twice in the middle age group as compared to men. If you compare a man whose MI is 45 years old, and if you compare a woman with MI in the age of 45, the same age, I would say that the mortality would be double. And why it would be double in females? Because of many complications associated because of lower BMI as compared to men. Bleeding complications are higher. During procedure, the complications are higher. And the recovery, again, it is slower as compared to men. Now, if you talk of hypertension, diabetes and dyslipidemia, very surprising that even hypertension is supposed to be higher in females as compared to men. So earlier, men were the sole breadwinners, they were the sole homemakers as far as finance was concerned, but now I don't think it's the same. Equal contribution is being given both by man and women in a house. And hypertension, surprisingly, has cornered the female more than men. So the incidence is more than men, and the complication and the event rate in women with hypertension is also more. With diabetics, you would say that all those females who are diabetics, they have 3 to 7 times the risk if they land up in any complication of coronary heart disease as compared to men who have 2 times more risk as compared to normal risk. So a diabetic lady would be having a complication rate of 3 to 7 times, and a diabetic man would be having a complication rate of 2 times as compared to a normal person who is coming with cardiovascular problem. So you can imagine how badly women are affected with diabetes, which is a very silent killer. People are not even bothered to control their sugar. So you have to create that awareness in all the ladies to keep their sugar levels down. You cannot just leave them like that. They keep their fasting sugars 100 and they are very happy. They keep their fasting sugars 200, 230, and they say we are okay because nothing is wrong with us. So you have to make them aware. Now nothing is wrong, but what is going to happen after a few months or few years, it will be totally out of control. And plus the peripheral arterial disease complications are also extremely high in women and extremely painful and pathetic in women. And you should understand, once they land up in diabetic foot, it is so painful to see the patient because you really can't do much. Even if you open the vessel, even if you keep on cleaning the ulcer, these things that do not heal fast. And the more you keep on seeing your patient who become chronic, the more disturbed even you are. At one point, even you start feeling the pain. You start feeling that how they are being cornered because of the smell, because of all those things. They don't lead a normal life. And varicose vein, again more common in females. Varicose ulcers, they never heal. And it is so painful to see the patient just, these are the things which can be prevented right from the beginning. If the doctors are a little strict with their patients, all these things can be controlled. Again, dyslipidemia, the incidence of lower HDL levels in women and higher HDL levels as compared in men. This is also very funny. Men have got a higher HDL level, whereas women have got the high density lipoproteins, which are good lipoproteins. We have got a lower concentration of HDL as compared to men. So So that means the protection level will start on decreasing as we go on aging. Again the same slide. HDL in men, we take the range as 36 to 53. So less than 36 in men will have more cardiovascular complications. Whereas in women, the level we see it is 46 to 67. So protection for us will begin if we are above 67, which we never achieve. You can take down your own fasting lipid level and you can see where you are standing. In 3 years back, my HDL level was 70. And everybody was surprised how you are maintaining an HDL level of 70. Even I didn't realize how I was doing a lot of vigorous yoga at that time. And I think that really helped me to maintain that level. And I thought that probably such a high level would not be good. But then all the retrospective studies have shown that protective level actually comes when it goes above 65 and 67 in women. But in men, it is 53 is more than enough to protect it. Now smoking. It's also a very sad situation and a very bad situation that now you see more of women who are into smoking. It is the style. I think they're trying to become the younger generation.
Gender equality.
Now we being seniors and we being mothers to all those children, we should be very tough with them and very strict with them, I guess, because if you see the college campus, whether it's a medical college campus, more of female students are into smoking. If you see pubs, more of female students are into pubs, and all this needs to come down. It needs to be stopped as fast as we can. We should condemn all these actions rather than feeling that they are becoming smarter and this and that. So this is to be taken seriously. And smoking has got higher detrimental effects in women as compared to men. Very high detrimental effects. Physical inactivity gives a reduction of almost 50% to all the events. If you are physically active, you do at least 30 minutes walk 3 times in a week, your protective levels will be almost 50%. So the reverse would be also that you have a 50% chance of suffering the disease if you do not do any physical activity, because our job, all of us, I think 8 hours we would be just sitting on the chair, as now also you are all sitting. The same we are doing, because you have to sit and see your patients, there is no option. And the more number of patients you have, the more harder you have to sit. So we have to find some way of doing a physical activity, whether it is in the morning or it is in the evening, at least 30 minutes, 3 times in a week. That will be enough to give us good amount of protection. Now obesity, diabetes is 40 times higher with the complications in patients who are obese. And obesity would mean a BMI of more than 30. A BMI between 25 and 30 is, you can say, somebody on the healthier side, but not actually obese. Overweight, you can say, but not obese. So obesity will be carrying a very high risk, particularly if the patient is adult. And in females, this figure goes to a very high number, maybe 30-40 times fold higher. CRP levels in the corona era, we have seen so many doctors and physicians doing CRP levels, because this is a very famous inflammatory marker. Since ages we are listening, and now it has been correlated, and the correlation goes again higher in females. So CRP levels higher in women would be really a very bad prognostic marker. Of course in men also it's not a good marker, but in women even slightly higher levels would give you a bad prognosis. Suppose a female with acute coronary syndrome and its corona is going on, we want to see this patient is coughing also, and we have done a CRP level, now it comes to 60. So you can imagine that the risk of this lady dying out of ACS would be tremendously high. So the inflammatory marker, if it is on the higher side, this shows the amount of heat and the inflammation that you have in your body. And how would the healing be if the inflammation is so high? MI is because of inflammation. What is MI? It is an inflammation. And if the inflammatory marker is suggesting that the level of inflammation is very high, that means a large amount of tissue has been geoparalyzed. So the recovery is also going to be very slow, and it may not happen also. Then autoimmune diseases which are twice as common in females, like systemic lupus or rheumatoid arthritis, it is twice common in females as in men. And if you have an autoimmune disease, then the risk of complication is 2 times to 2.7 times higher if you vis-a-vis if you do not have it. Suppose a patient with SLE walks with a chest pain, so we must understand before you offer any procedure that the risk will be almost twice higher in this lady as compared to a lady who does not have it. So autoimmune diseases, anything, whether it is pregnancy, whether it is MI, whether it is chest pain, whether it is stroke, the incidence of complications is going to be 2 to 3 times higher. Then PCOD, Today, many young ladies are suffering from PCOD. All those ladies who are having, young ladies who are having PCOD have a higher chance of developing hypertension, higher chance of developing diabetes in the due course. And most of these females are also overweight to obese. So again, everything boils down to the same thing. Your physical activity levels should be really good. Patients who suffer from eclampsia, that means who are hypertensive during their pregnancy, have a higher chance of ending up with pregnancy with hypertension post-pregnancy. And the hypertension does not cure easily. And I have seen not many patients postpartum they come with PPD for a saal, 2 saal, 3 saal, 5 saal ho gaye, young ladies having good amount of hypertension. Also, the risk of thromboembolism becomes very high if your patient has some pre-eclampsia. These are certain just facts that we should be aware of. Now, surprisingly, patients who come with chest pain have lesser incidence of obstructive coronary artery disease. Obstructive means if I do an angiogram, 70% lesion, 80% lesion. This kind of picture will not be presenting a female mostly who is having a chest pain. Still, the mortality is higher. See the paradox. A male coming with 80% blockage and we say blockage has 10 days, ठीक हो जाएगा. But what about if you do the angio with a lady who is having chest pain? You must have seen in the hospital, Dr. Shweta, you must have realized sometimes that we do the angio and we report it as normal, कुछ था ही नहीं, and still the lady succumbed in ICU. Why is it happening? This is really funny and it's a paradox. But then again, this paradox is also seen in females. This is known as cardio syndrome X. Everything is normal, there is non-obstructive lesion. But the LV function goes down, the lady has chest pain. Now what do you attribute it to? Why did she succumb? Why did she die? It's very funny. That's because the microvascular circulations are damaged very nicely in females as compared to males. Even if you open a vessel, suppose a lady comes and you open the vein, we see a lot of slow flow in females. And if a male is there on the table, they do pretty well. Thoda sa dilator diya and they are all right. But in a female, you keep on giving nitro, you keep on giving Nicoran, they don't, the small vessels is like चाय में से आप छन्नी में से चाय छानते हैं, देखोगे छन्नी में से कभी भी चाय बहुत धीरे धीरे जाती है. अब क्या करते हो उस छन्नी को अच्छे से क्लीन करते हो, स्क्रबर से क्लीन करते हो, so that the micropores are clean. But in females, these micropores create a lot of problems which are not visible on the angiogram. Nobody can see them, but it's our assumption. So that microvascular non-obstructive disease is very high in women, and it is like, you are not labeling it as something. You report it as a normal angio, you report it as a microvascular dysfunction, and still in the due course you listen that, oh, the lady finally she succumbed. But why did she die? Then everybody will discuss angio तो normal है, डॉक्टर ने कहा था ना, ठीक है. नहीं, डॉक्टर ने कहा था कि नीचे की छन्नियाँ ब्लॉक है उनकी. So these small vessels are also very important for us. And how do you cure them? We don't have those micro stents to go and place. We don't have anything. So what do we have in our hand? We have the prevention. Certain things that are in our control. So that has to be thought of. That has to be taken care of. Now, the premenopausal, the menopausal and the postmenopausal era in women. Let's discuss this very clearly. In the premenopausal age group, the women are in the low risk group. All those ladies who are menstruating, we say that इनको MI कभी नहीं होना, which is true also. They are actually falling in the low risk group. Ladies who are approaching their menopause, who are approaching say 45, 50 or maybe 52, they come in the intermediate category risk. Intermediate risk category. If they say we have chest pain, we should take it more seriously and you should act on it. And those ladies where they have already achieved menopause, whether it is 40 or it is 55. Menopause is menopause. Now age we are not discussing, we are discussing the menopause. Those who have achieved their menopause in younger age group, very sorry, they have a very high risk. Now they fall in the high risk category. So those ladies should not play around, neither with lack of activity, neither with smoking, neither with lack of sleep, and neither with diet. They should be very, very particular. Once you have achieved menopause, now all the protection has been taken away from you. You are standing just next to the man and with a higher complication.
Gender equality.
Yes, so you have to be very, very careful. Okay. And now, cardio syndrome X I already described. Two more things. Takotsubo cardiomyopathy these days now, because it is being very frequently diagnosed, it's being heard of, maybe you would have also heard of. So Takotsubo cardiomyopathy is where the angiogram is normal, the LV function suffers because of stress. The most common cause of Takotsubo cardiomyopathy is a stress. It can be a mental stress, it can be a physical stress. One example I'll tell you. I used to go to Shivaji Hospital, and there we had an administrative officer who was just due to her retirement, and every day I would say hello to her when I used to come out of the hospital. Very pleasant lady, and I would love to chat with her because she was very sweet and very nice to me. So every day I would say bye bye madam, and she would say one passing remark, oh I'm going to retire in another month, no, God knows how I'll do, what I'll do at home. This kept on. For 30 days this sentence was just in my mind. Oh, I'm going to retire now. What is going to happen? How my life would be? I don't really know. Maybe I'll start up a small clinic, doctor. You will come to my clinic, no? I will, yes ma'am, yes ma'am. And finally when she retired, within a week, in the middle of the night, she had chest pain. She was brought to my hospital. Emergency, I did her NGO. NGO was normal. Echo showed clear-cut apical balloon. She suffered from cardiomyopathy, which was really stressing. And she recovered. They recovered. These patients recovered. And 80% of the times they recover. But see, these things can happen. So stress is a very bad thing. If something troubles you in your mind and it keeps on troubling you, उसको connection cut कर दो जल्दी से. पता नहीं वो कब आप तक connection cut करा देगा. It is very very important. So mental stress is really dangerous. You should be very careful. You should not take it कि हाँ कुछ नहीं हो रहा है, सोच ही तो रही हो. नहीं सोच नहीं रही हो, आप सोच के बहुत कुछ खराब कर रहे हो. तो वो बहुत important है. जल्दी चीज़ों को फटाफट switch करना चाहिए. This is what is status cardiomyopathy. Now, one word about bypass surgery. So females also are undergoing bypass surgery now. It's not that they are not going, but to understand that the incidence of depression following bypass surgery in women is little higher than in men, because the chest once opens, there are a lot of things which change for the patient. So, and the recovery rate after bypass surgery for females is also little slower. Otherwise, the results are good, but these are the two things that you should understand. So, because if any of your patient after CABG comes to you, you should be aware that she may have a little depression, and because the incidence of depression in women after they go major surgery is anyway always higher. Other thing is that many patients are also undergoing valvular surgery. But you must understand that it's a paradox that after valvular surgery, whether it is mitral valve replacement or aortic valve replacement, women do better than men. They don't have depression, although the chest is also getting open, but we don't understand why it is happening. Valvular surgeries, the women do better. Heart failure, yes, up to 40 years, both men and women have got similar incidences, but after the age of 40, as the age increases, maybe you can say as you are approaching menopause, the incidence of failure in women becomes higher as compared to men, the heart failure. One word about peripartum cardiomyopathy, which you all should advise your patients. You would be seeing that patients who deliver, this cardiomyopathy develops from 6 months of your partum period, which means from your second trimester, 6 months of your pregnancy, up to 5 months postpartum. This can happen with any lady who comes to you with breathlessness. Don't dismiss कि just anemia होगा. Get a 2D echo done. She may be having something else, and that is known as peripartum cardiomyopathy. The incidence is almost 1 in 4,000, which I would say in our country is a pretty high incidence. 140 करोड़ की आबादी है. बहुत सारे दिखेंगे, बहुत सारे दिखते हैं हमको. तो डिसमिस नहीं करना ये सोच के कि एनीमिया है और कोरोफर दे दो ये तो नो. Get a 2D echo. सांस फूल रहा है जरूर कर लो. You must do, because this cardiomyopathy has got a very high mortality rate, almost 50% and above. And you must also advise your patient the second pregnancy can actually be fatal. So if any lady with pregnancy having this cardiomyopathy, your first advice should be get a sterilization done. If you have another child, maybe you would not come up to the term only. You have to be very harsh, your words have to be very clear to the patient. Nobody can save them. Even if the second child is born, what would be the good, who would bring up the child if the lady is not there? So this is a very important thing, peripartum cardiomyopathy. If there is nothing which you can avoid. You see, these are all genetic. Many patients do have this cardiomyopathy during pregnancy. There is no hypothesis why it is happening, but it is happening. And now one word about arrhythmias. In females, long QT is very common. Sudden death is very common as compared to men. The incidence of stroke in a lady who is having atrial fibrillation is also higher in women as compared to men. So you should be giving them good amount of anticoagulation. You should make sure if you are not writing, at least the index person to whom you refer should be writing the patient should be nicely anticoagulated, particularly if the patient is a female. So these were the all few headlines how a lady would be differing from a man in all these aspects as far as cardiovascular diseases are concerned. So this was the presentation, and any questions are welcome.